So we want to know how much of relevance that this discussion has as well, particularly in a context like Chile, in which it is the last insurance, at least for the period that we're going to look at, is the last insurance against pregnancy. What has been found so far in the literature is that really there's nothing, particularly regarding emergency contraception, is that the effects, or at least in developed countries, rather limited. So for teen births for the UK, there's not all that much. If anything, we see an increase in sexually transmitted diseases. So it seems that it might be a bit of compensating behaviors, that people stop using other methods of contraception, particularly condoms, because those prevent STDs, and we see an increase. But not, particularly not much that justify for this very wide polemics of discussion. For developing countries, we're going to focus on the Chilean case that has been previously studied, and I refer to previous literature and see how our results can compare to those and what do we find. So with respect to also related literature, this discussion of everybody's going to go crazy and use this overly much has to do with the results on the literature on compensating behaviors. That's those 3 papers there because they're kind of fun and intuitive that this how people change their behavior. Particularly the last one is when these tops on the US on bottles that are like very hard, and the first time you encounter them, you don't know how to open the damn thing. Actually, when those things were introduced for aspirins, the amount of children that actually entered the ER with an aspirin overdose went up rather than down. Because people closed it, or maybe they didn't close, but now they were so safe that they didn't put any care anymore, leave everything around, and this thing happened. So there is evidence in human behavior in general that when things that become a bit more safe, people act crazy, or don't take the precautions that they used to take before this new technology, so to speak, was available. Same thing with safer cars make people drive more risky, and seatbelt usage didn't really change anything on actually the consequence of traffic accidents, because people kind of behave a bit more crazy. So there is a risk that people are going to, when there is better technology, better insurance technology, people are going to behave. They're going to change their behavior and adapt their behavior to the existence of the new technology. Regarding sexual behavior, there is a bit of both things. So there are papers that actually having subsidized contraceptive did not actually increase sexual activity. So it's not that now that sex is safe and we're not going to, now accessing the pill in particular is cheaper, that doesn't seem to be accompanied by a very large increase in sexual activity that is actually going to counteract the fact that the probability of pregnancy is substantially lower. There are other maybe more complex settings, like with shotgun marriage or post-pregnancy marriages, that contraception availability and abortion seem to actually have a bit more, let's say, general equilibrium effects with changes in the preferences for a promise of marriage or one of these type of marriages that people have. And there is also some evidence in the middle paper that people react differently to these things. So it's not only that you observe more or less fertility, but it's also the type of women that actually become pregnant and give birth seem also to be changing. And actually after maybe the introduction of the pill or some changes in the prices, I don't remember exactly, they observe more children with low birth weight, signaling that actually women who give birth to children that are never in the category of low birth weight are actually taking advantage of this new technology properly, reducing the number of pregnancies that they are having, while women that may give birth to this type of children are not. So they have different effects, also for different type of women. So what are we going to do, and why is this Chilean case interesting in this context? The Chilean case is interesting in this context on the one hand because it allows us to see things, hopefully, or there are changes that I will go over in a second that allow us to see things, but also because the emergency contraception at the time we're going to study is the last type of insurance against a pregnancy. So abortion is not legal. There's no cases for this period in which abortion is legal. There is illegal abortion, but it's obviously much more costly. But in a way, there is no further risk, further insurance that they can have once the risk is realized. You take the pill or don't take the pill, but that's kind of about it. So if there is not much evidence that a lot of things are changing in this context, one could expect that this, if anything is changing here, other countries will have a lower effect. So because that's other countries will have a posterior layer of insurance that in this case is absent. So why why there are so many changes and what's happening in Chile? So one of the things that is going to allow us to hopefully be able to say something is the fact that the Chilean constitution protects the life of those soon to be born, kind of literally. And that implies that they don't have abortion, and also that anything that is slightly abortive or that anybody thought one day that there might have been some abortion, abortive element involved, gets challenged pretty easily. So, and this was what happened before the period that we're going to study here, before 2007. So there was a challenge to the Constitutional Court. This thing cannot be sold in this country, not even in pharmacies, not even if the government does nothing with it, because it's abortive. The Supreme Court said there's no sufficient evidence to consider that. So this thing can be sold here and distributed. And the situation before February 2007 was such that the emergency contraception was given away in the public system in the case of rape. It was available in pharmacies, not in all of them, so quite reduced share of pharmacies, because obviously this thing is not exogenous. So it's the fact that the Chilean constitution includes that reflects preference from a share of the population, and that's also reflected on the fact that some pharmacies, some chain of pharmacies refuse to sell the pill, the emergency contraception pill at least. But technically one could find a doctor, a private doctor, that will write a prescription and you will go and buy it. But that's much costly than going to the public sector and get it for free, which you could do only if, in the case of sexual aggression. In February 2007, there was a change in regulation that's going to start the things that we could use in our case. So there was only distribution in case of rape here, and there was a decree from the health ministry in February 2007 that regulated the distribution of contraception, including emergency contraception. So for a period here, there was free distribution. You could go to your local clinic or to the hospital and get the emergency contraception pill with no problem whatsoever. Till the Constitutional Court ruling came along in April 2008. From April 2008 till at least June 2009, it was a very particular situation. From 2009 till the law in 2010, it was clear that nobody could give you the pill for free. Here, it was a weird situation in which it was clear that you could not go to a federal hospital to get the emergency contraception pill, but it wasn't clear whether the local clinics that were run by the city halls were considering a public sector or not, as per the Constitutional Court. So what you find is something like this. I have a co-author that is a development economist, and apparently you have to have pictures. So I put them in the appendix. But, so you could not go to a hospital. I mean, you could go, but they were not going to give it to you. But if you were to a local clinic that were run by your city hall, you may or may not have it available. And you may or may not have it available, depending, among other things, on the decision of the mayor, which is obviously we're going to use to try to see what's going on in this case.
But everyone can go to both hospitals, to both clinics?
So you have to go to the clinics on your municipality. Technically, you have to be registered with the clinic of your municipality, and you have to go to the clinic of your municipality. Well, there is
and to go to the hospital, what do I need?
So you can go to the hospital if there is an emergency. But they were the hospitals, the federal hospitals, reverted back to this case. So you cannot go and say, oh, I have sex with my boyfriend and the condom break and I want emergency contraception, because they were in this case. While the local clinics, they may or may not have reverted to this case.
But the local clinics were for free, so it's...
Local clinics are for free, yes. Yes, most of the whole variation that is happening here comes from those that are associated with the public service, which are the poorer part of the population. I think maybe 60 or 70%, the poorer part of the population is associated with the public service, with FONASA, and they're gonna be subject to all these changes. So there was a law, actually in 2010, that allowed you to get the pill, particularly because the court ruling criticized this being a decree instead of a law and some technicalities along the line. However, at some point there was a change in government, and actually the lower rank rule that actually fixed the small detail of how to do this only came till in 2013. So here there was a kind of a gray area that you never knew. Well, technically you would have the right to get it for free, but nobody knew exactly how this thing was done. So till actually the reglamento or decreto came along in 2013. So that's hence the quotation with the free distribution. It may or may not happen. So this is the situation that we're going to explore. So we're not the first one to explore this situation, and this is a paper from Cora and Clark that came out, I think, last year, that explored the same policy changes. And what they find, what they use is a survey of municipalities. So someone called the municipalities in these 3 years and asked them, do you give the pill or not, at a quasi-random point during the year, and they use this variation with some some extrapolation before and after this. So this is a table right from their paper. So they claim that they find a significant decrease and a sizable decrease in the birth rate of women when they consider all women, particularly so for those that are 20 to 34 years old. I think on the one hand, the results are very noisy, so may or may not find that. And also, there might be many other things that are happening at the same time. Because these numbers are, at least the way I interpret them, are very, very large. They go from a 1% change to a 3% decrease in the birth rate, while, for instance, I think Kearney and Levine, for actually an inclusion of the regular pill, not the emergency contraception pill, the regular pill on the Medicaid, they found a 4% decrease for teenagers. This is the regular pill. Well, this is the emergency contraception pill that you can use at most a handful of times a year, that you have to take after, and then you have to condition all those things that you actually have to have gotten pregnant, that sexual relationship in which you're actually using the emergency contraception pill. So to me, these numbers look very large. If there is a decrease, it seems to me that these numbers have to be capturing something else that is not just that you took the emergency contraception pill and the time that that you got that you were going to get pregnant. So what do we do here? We're going to try to do two things. I think one of them a bit more successful than the other. One thing we're going to try to do is try to see if actually this yes or no thing driven by the mayor is actually capturing other characteristics as well. I'm going to try to use close elections for that. So mayors that were very close to winning or losing, the right-wing mayor, the left-wing mayor, to see if there is something there. Unfortunately, it's pretty noisy because we only have so many municipalities, and we can only use one elections that happened in 2008, because that was after that when actually the mayors have something to say about this. And the other thing is we're going to try to say is whether this thing is capturing this policy change is actually affecting much more than having emergency contraception available. So we're going to try to use this thing. The fact that we have one in 2006 is actually very useful for us, because what we're going to be using as to see whether there is emergency contraception available in a municipality or not is to see whether someone has claimed that they have used emergency contraception for their last sexual relationship. That's what we're going to be using. And obviously, this thing always operates. You can always get it if you have been a victim of rape. So we can use this as in this municipality, if this was a case, what was the kind of baseline use that we can think it was in this case. And we can compare municipalities in which the change in use was significantly from 2006 to 2009, and 2012 as well. So which type of data do we have? I'm going to go rather fast over this. So we have data on which type of contraception did each of the young people use in their last sexual relationship. We have condoms, pills, emergency contraception pills, a bunch of stuff, and others, wherever that is. If within your municipality there was someone that reported they have used emergency contraception in their last sexual relationship, I'm going to assume, with the caveats that I just mentioned, that it was available for you to access. The nice thing of this survey as well is that actually we have other risky behaviors. So we can do kind of placebo test or falsification test that is actually people in these municipalities are not more risky per se. And we have a bunch of controls that we can also use to try to see if there is actually balance, any difference that there might be. This is some descriptive statistics, and obviously some emergency contraception jumps a lot, particularly from 2009 to 2012, and also 15. And there are other types of contraception that become less popular, so to speak, like the intrauterine device. That's a similar thing that we have seen in other places.
There's a very big increase in condom.
There's an increase in condom from here to there, which is a bit, I would have expected for this to increase a bit more once we have the first norm in there. One can definitely check if there is any other policies that were implemented there. That's definitely something we should check. So the first thing that we check is obviously, do people, quote unquote, go crazy? We have the probability of whether they have had sex already for people that are 14 to 29, and we can check whether controlling for fixed effects and a bunch of characteristics, having the emergency contraception pill availability has an effect, and that doesn't seem to do anything.
Do you also have like how many times? Because you know, if somebody goes crazy, it's probably those that already have some experience.
Yeah, I don't have information. I have information on whether they had ever had sex or not, and what did they do the last time they had sex.
Okay, you don't know.
I don't know whether anything, whether the intensive margining changed or not. Let's put it that way. I have no information on the intensive margin. I know whether they were using certain type of contraceptive in their last sexual relationship, particularly any method, which they don't seem to change. And then I hear condoms, pill, emergency contraception, and obviously others. Obviously emergency contraception, given that I'm having everybody here, including the ones that report having emergency contraception, that is going to increase, because that's kind of. But we also see increases in the use of the regular pill for those that live in municipalities that they have emergency contraception available. And we see a decrease in other, which is unclear where it is to me, but maybe things that are not actually emergency contraception, and people are referring to as other things that are not actually contraception, but people are referring as them as so, but it might be things that definitely don't count into what one could call modern or highly effective contraception.
Do you know if it's a regular partner, the last sexual intercourse, or it's like a casual thing? That implies very different things.
We might. I'm not sure. I know, for instance, for 2006, we have information about their first sexual relationship as well, but they don't ask in the other waves. And there, I'm sure we have information on whether it was with boyfriend or or was. But I don't know. We should definitely check that as well, whether this was something that was kind of in a well-established setting, so we can actually see whether this is a long-term trend as well. So one thing that we also wanted to check is whether there is evidence of this kind of information channel that I kind of see on when we see of increase in the emergency contraception pill. So we have information of the background of the household head. And so I'm considering here the household head has high education if they have at least completed secondary education, and low education if they have not completed secondary education. And we observe here, if anything, it seems to be located most of the effect on those that are in a household with a head that has higher education. So these might be the people that are more likely or more able to actually process the information that is given to them. And I think this also, a lot of people will know better than me in this audience, but it's also in line with the fact that people that are highly educated tend to do better things for themselves and take better care health-wise of themselves as well. Potentially because they are more able to process that information that is given to them. How am I doing with time?
You're doing good.
Oh, that's plenty. That's plenty of time. Let me show you this. At some point, I thought I didn't have a lot of time. So, one other thing that I try to check is whether there's actually this higher education or lower education is actually capturing kind of background money, even though controlling for those. But when I divide the sample of high socioeconomic group or low socioeconomic group, this doesn't seem to be all that much that is going on. It's not that these people that were in a household with a head that has higher education were actually more likely to be able to take some time off to go to a doctor and get their regular pill or anything like that, because for both people, let's say, better off or not so well off, the effect of the use of the pill appears to be very similar. So it's not that these people have to go to work and cannot do anything and so on. So it doesn't seem to be fully driven by the fact that some people can maybe afford the pill and other people cannot. So one obvious result, one thing that might be of interest, is actually know whether we're just capturing different characteristics. People are very risky in certain municipalities more than others. The mayor may know this and say, well, we cannot have a bunch of teenage girls being pregnant. Let's just have emergency contraception available because people are going to act crazy in any case. It doesn't seem to be the case. So when you have risky behavior that is not related and is not affected by the emergency contraception, cannot be a goal of the measure, we really don't see anything. We don't see people are more likely to drink alcohol, smoke cigarettes, smoke marijuana, do cocaine. There doesn't seem to be all that much going on in this type of outcomes. So that's, in a way, it's a relief that we are not capturing the riskiness of the municipality person, or anything else to relate with that. Or maybe the risk aversion of the municipality, given the sign of the result that we are finding. One of the things that we thought we were going to find when we started the paper, and I think at some point the paper was called Unwanted Consequences or Undesired Consequences rather than just Consequences of Emergency Contraception Availability, was the fact that people were going to switch potentially away from things that can prevent STDs particularly, and we're going to observe a large increase in the number of STDs because people were going to move away from things that can prevent STDs. We don't have a condom, doesn't matter, because we can go do this thing. And we really don't observe all that much. As a caveat, I think I should say, I think it's for syphilis, but I always get this wrong. Probably we're doing this thing contemporaneously, and that's probably not the best measure, because this thing takes a bit to show up, let's say. We have number of people that actually are diagnosed with either gonorrhea or syphilis in the municipality in a given time, in a given year, and we regress it in the same thing, in the same set of covariates, adding population now, because we're just adding the number here, and we don't observe that actually having emergency contraception has any impact on these outcomes as well. So,
but this is again survey with the same survey, no?
No, these are our administrative data. These are what they call it, enfermedad de notificación obligatoria. So there are sickness that the hospitals or the local clinics are obliged to report to the government. And these are the two STDs, I think, that they report, but there are hepatitis and maybe whooping cough and these type of things that you want to keep your statistics, let's say. So these are the numbers that are reported in a given municipality at a given time. So they don't ask about STDs. I think they ask whether they know what HIV is and things like that, but these are for the entire population as well. So yeah, we don't observe all that much there. So it seems that the direct effect might be a composition of actually two things. One is obviously there might be the case that we have less births because we take emergency contraception, but it might be the case that we observe less births because we have more information about the regular pill or about the risk that we are taking when doing that, along with the emergency contraception gives information or other, maybe awareness of the risk that you're taking, because now you go there and you're thinking for at least a day or two whether you're actually pregnant or not, and everybody gets worried, and maybe those things makes you change your behavior as well. So it might not only be emergency contraception, but also other things. We don't observe any compensating behaviors, and I don't remember where I put this. So there is other type of positive spillovers that might be capturing when we are estimating these things that might be interesting to take into account. So there might be other measures that we can use actually this information to implement different types of policies in this context. No, that's definitely a fair point. And one thing that we definitely do is focus on the part in which we might be capturing at least some of the fact that we have some external decision being made regarding the availability of the pill there, unlike using 2015 or 2006 for variation there. No, but that's something that we should definitely look at. No?
Questions? Luigi? No?
Can people get the pill through internet?
I mean, maybe you can at the time, but technically there might be easier ways of getting it. It's just much more expensive than getting it through.
It can never be expensive.
Well, if you account for, so you have to be pregnant. That's the thing for this. So if becoming pregnant in one single.
You can have a stock.
You can definitely have a stock, but my point is that it's unlike the abortion, when you know whether you're pregnant or not, when you take the emergency contraception, you just know you've taken a risk. So you're, in a way, if people know how they kind of do things correctly in their mind, that will be not so different from the choice of using a regular contraceptive or not, in the cost ways.
That's right, but if you go to your municipality and then they say, oh, sorry, I don't have it.
Yeah, definitely.
Then you're in trouble, right? Well, you have
So, so technically, you can go to a private doctor and get a prescription and pay for the private doctor, obviously, and then pay for the prescription, and then you could always obtain it that way. But the cost, obviously, of doing that is much higher than going to the local clinic and just have it handed to you. That's, so this availability is obviously availability at zero cost. Because in, I would say, quite a few municipalities, that would be somewhere where you can find it.
How widespread is the knowledge of the availability on the demand side? Is there any sample selection going on across? Do 14 to 29-year-olds know it's available? And if not, then that could you kind of lower bound on a lot of
My guess, and that's probably only an uneducated guess, would be that people were quite aware of where things were available or not. So it was obviously when particularly the Supreme Court ruling were all over the news. That was something that was very well known, that it happens and now this thing is not going to be available. And there was also, even nowadays, you can go back to old chats back in the day, and there were quite a few places that will give you kind of a list of municipalities where you could get it, or if I'm this municipality, I'm going to get it or not, and so on. So my guess would be a decent amount of knowledge was going around.
Related to that knowledge, I was reading, and I remember in 2009 it started like a feminist movement over women's rights because of this. So they were kind of informing other women how you can make a pill with a combination of normal.
Yeah, that's the other.
Really user you could like see in the street, no, like really people following.
That's yeah.
If they say yes to that, if they in the survey they say yes when they did that instead of easy pill, they say they did easy pill because in theory it's the same. How they deal with that.
That would be the other alternatives. Try to kind of concoct your own pill. But for that, you actually need to have emergency contraception available in order to do these things. So you will need to go to your city hall and get, and that might be one of the ways that this thing is also appealing. You go and you don't say, oh, I need the emergency contraception, but you say I need the pill, and they give you the pill, and then you have it there, and maybe you learn about these things, and you start using this. But you still need to have the regular pill in order to do this thing.
I don't know the instructions in the papers on the street. I don't really know if this has
Yeah, no, that's.
Go to your private gynecologist, so they will give you for free one sample and use that sample.
I thought you.
I don't know if it's,
Yeah, no, I definitely should look more into that. Yeah.